Hey everybody, welcome back to my YouTube channel. My name is Ashley Agan and I am a board certified ENT doctor. In this episode, we are going to be talking about tonsillectomy. So if your child has been recommended for a tonsillectomy or a procedure to remove the tonsils, then this video is for you. We're going to go through what to expect, what are the reasons to take the tonsils out, and answer some of the burning questions you might be having. So just to kind of set the stage, what are tonsils and what are adenoids? So tonsil tissue, it sits right in the back of the throat. If you open really wide, you might be able to see these two balls of tissue that kind of sit right at the back of the throat. Those are called tonsils. The tonsils are what we call lymphoid tissue, which means that it is involved in our immunity. So tonsils are involved in developing our immune system, which is why they are larger when we are younger, when we're in that time of life, when we are developing our immune system and being exposed to new germs and viruses that our body has never seen before. The adenoids are essentially a similar type of tissue, but instead of being at the back of the throat, they are straight in the back of the nose. And together, the tonsils and adenoids make up part of a ring of tissue called Waldeyer's ring that's sitting at the back of the nose and throat. We also have lingual tonsil tissue that sits on the very back of the tongue that you can't see. And so this tissue can become enlarged. It can become chronically infected, and these are some of the reasons that we might need to remove these in kids. In my practice, the most common reason for tonsillectomy with or without adenoidectomy, or sometimes just adenoidectomy by itself, would be snoring and sleep-disordered breathing. And so sometimes the tonsils and adenoids can become so enlarged that they are actually obstructing the airway. And kids can have really loud snoring, mouth breathing. Sometimes they can even pause or stop breathing when they're sleeping. Parents will sometimes tell me that their child is snoring like an old man or an old grandpa, and they can hear them even outside of the room. Sometimes the signs and symptoms are more subtle. So maybe there is some snoring, but it's quiet. It does seem that they have trouble breathing through their nose. There might be mouth breathing. Sometimes kids will sleep with an extended neck. So they'll extend with mouth open just because that's the position that allows them to breathe the best. And then the daytime symptoms for kids can be things like irritability or hyperactivity or aggression. It may not always be them feeling tired or sleepy. Sometimes it can be, but in kids, it's hard for them to voice or explain what it feels like to just be sleep deprived because they're not getting good quality sleep. Sometimes bedwetting can be a sign of obstructive sleep apnea. So if your child was previously potty trained and then there seems to be some regression and now they are wetting the bed more often, sometimes that can be a sign of obstructive sleep apnea or sleep disordered breathing. And so these are the signs and symptoms that parents are coming in and telling me about. And then obviously when I'm examining children, we are looking in the mouth, looking directly at the tonsils and how they're sitting at the back of the throat. And then for kids who will allow it, I like to perform what's called nasal endoscopy. And this is where I use a very tiny little flexible scope. The scope is about 2.7 millimeters. And we just slide it inside the nose so that we can see. Number one, it helps us see what the nose looks like because some of these kids do have allergic rhinitis or inflammation in the nose that's related to allergy. So there might be a lot of mucus or swelling, and that can also can contribute to poor breathing and poor sleep. And so it allows me to see what's going on inside the nose, but then I can also slide back and see what's going on in the back of the nose where those adenoids sit. And for some kiddos, the adenoids are completely obstructing the back of the nose. And that's why they are mouth breathing, because they simply don't have an open airway all the way to the back. And so once it is decided that we are going to proceed with tonsillectomy plus or minus adenoidectomy, so removing the tonsils and or adenoids. Let's talk about what that entails and what surgery looks like. So a lot of families have heard really horrible stories about how painful tonsillectomy surgery is, and kids won't eat or drink for 2 weeks, or they had to stay in the hospital, or they had some bleeding afterwards and had to go back to the operating room. All of these stories that I think for some parents it can be really scary electing to proceed with surgery because they just have heard scary stories and are not excited to put their child through something like that. So what I want to introduce is that tonsillectomy surgery is performed very differently than it was even 10 or 20 years ago. And the technique that I use is called Coblation Intracapsular Tonsillectomy. So the difference between Coblation Intracap, we'll just call it Intracap for short, and traditional tonsillectomy is that in traditional tonsillectomy, heat or cautery is used to remove the entire tonsil, including the capsule. And that once that is removed, there's just a wound in the back of the throat on both sides. And because of that, it's very painful because you have those muscles and nerves are just exposed until the body can heal from the bottom up. And so the recovery is a very sore throat for a couple of weeks. The Coblation Intracapsular technique, I will use the Coblation device and I dissolve the tonsil tissue down to the capsule without violating or removing the capsule. The benefit of that is that the capsule stays there and protects those nerves and blood vessels that are running along the sidewall of the throat. And so the pain is significantly less and the bleeding risk is less. And so in traditional tonsillectomy, the bleeding risk is about 2 to 3%. So it is very low. With Coblation Intracapsular tonsillectomy, that risk falls to about 0.5%. So very low. It's not zero. There is still risk of some bleeding. However, because the capsule is intact, the bleeding tends to be a lot less brisk and may even stop on its own. And with the introduction of this technique in my practice, what I can tell you is that most kids are itching to go back to regular activity within days. It is not uncommon for me to get a text from a parent saying, hey, my kid wants to go to this play date. It's only been 3 days since surgery. Is that okay? Or they want to go to their swim meet, or they want to eat a hamburger. And so the difference is remarkable. And I think for my families, time and time again, the parents will tell me that it was a really great experience and that they were really glad that they did it. And the kids really recover and bounce back well. And that is because of how different this Coblation Intracapsular technique is. And if my child needed a tonsillectomy, this is the technique I would choose. So as far as day of surgery, what to expect. So for most of these kids, they are going to have what we call outpatient surgery, which means that they come in the morning of, and then after surgery, once they are awake and recovered, they will go home the same day. Kids who are under the age of 3 and kids who have been diagnosed with severe obstructive sleep apnea on a sleep study, these kids need to stay overnight for observation. So they're going to actually stay in the hospital and then will likely go home the next morning most of the time. So kids under 3, kids who have severe OSA, and then there are also kids, any sort of medical comorbidities. So if they have other medical problems that we might worry about that might interfere with recovery or make it hard for them at home, we might keep them in the hospital too. But in general, for an otherwise healthy child who just has big tonsils and snoring, most of those kids are going home on the same day. So you'll come into the surgery center fasting, obviously, so nothing to eat or drink after midnight. And the reason for fasting is because tonsillectomy surgery involves what we call general endotracheal anesthesia. And so once your child goes off to sleep, the anesthesiologist is going to put a breathing tube into the airway to protect the airway from any drainage that might be coming down, because they'll be completely asleep and I'll be working inside the mouth. And if your child has a full stomach, if they have breakfast or something like that, then there's a risk of what we call aspiration, which means during the process of putting that breathing tube in, if they were to have reflux of food or liquids up into the airway or up into the back of the throat, that can go into the airway and that can cause a pneumonia, and kids can get really sick. And so that's why they have to be what we call NPO, or have an empty stomach essentially before surgery. And we do all of our kiddos surgeries in the morning. That way they don't have to be cranky and hungry later in the day. So they'll come in with an empty stomach. Our nursing team will meet you guys and get you all settled and ready for surgery. I'll come in and say hello. The anesthesiologist will come in and say hello. We do have an option for what we call a pre-med. The pre-med is a little medication that's taken by mouth that just helps make anxious kids a little bit sleepy or more relaxed. And this is an option. I think if you have any concerns that your child might have some separation anxiety and might have a hard time leaving you when it's time to move back to the operating room area, I think a pre-med is a great idea. Once we head back to the OR, the parents, you will head to the waiting room. In the operating room, we will get your child all situated on the operating room table and off to sleep with just a little bit of mask anesthesia. So they'll breathe in the anesthesia gases, so then they go off to sleep. And then the nurses will place an IV and the anesthesiologist will put the breathing tube in to protect the airway. So once that's all done, we'll get set up for the surgery portion. Tonsillectomy surgery goes through the mouth, so there are no incisions or cuts or anything outside the mouth. A retractor is placed to be able to hold the mouth open and view the tonsils, and then the coblation device is used to dissolve the tonsil tissue down to the capsule. For the adenoids, sometimes, depending on the size, sometimes I will view them through the mouth with either a curved mirror or a scope. Sometimes I will put a small scope through the nose, since they are straight in the back of the nose, to be able to have a better view, with instruments going up through the mouth, again, to dissolve that tissue down. And so once the tonsil and adenoid tissue are effectively dissolved down such that there is a better airway, that concludes the procedure, and we take the patient back to recovery, where you will come meet with them as they are waking up. Some kiddos wake up just like they're waking up from a nap. Some kiddos wake up a little more delirious. It might feel funny because of the anesthesia. And so all of that is normal, and you and the nurses will be there to kind of help keep your child comfortable during that time. So once you go home, the big things to look out for, to be aware of, obviously pain is the biggest one that we worry about. And even with the intracapsular technique, they've still had surgery, so they still will have some pain, but compared to extracapsular tonsillectomy, I would say it is significantly less. So my typical protocol for pain management is a combination of a medication called celecoxib, which is a non-steroidal anti-inflammatory medication. So it's kind of a cousin to like Motrin or Advil. The thing that I like most about celecoxib is that it's twice a day dosing. So it's a very long-acting medicine, so you don't have to give it as frequently as Motrin. And so for kids, you're going to open the capsule, sprinkle it into some applesauce or pudding, and give that to them morning and night. And then throughout the day, you can give liquid Tylenol, because Tylenol works in a different way than the celecoxib. So you're getting different types of pain control using those two pain medicines together. And for the first couple of days, I would say give maybe 1 dose of Tylenol in the middle of the night, and then just kind of see how they're doing. If they seem like their pain is well controlled, then after a couple nights, just let them sleep through the night, and you can just have it ready in case if they do wake up with some pain. But again, with the intracapsular technique, I find that pain is less of an issue for these kids compared to traditional tonsillectomy. And so that's my typical pain medication regimen. Some kids might want to do the chewable Tylenol, which is fine. Some kids might prefer the liquid Motrin, which is fine. If you did decide to do Motrin instead of celecoxib, then you would just take that every 6 hours. And so you can alternate the Tylenol and Motrin. So another way to do it would be to either give Tylenol or Motrin every 3 hours, kind of alternating them back and forth. So for example, you would give Tylenol 3 hours later, Motrin 3 hours later, Tylenol, back and forth like that, which is totally fine. It's a lot more dosing, but that is also an option. Sore throat is normal. Ear pain is normal. The tonsils and adenoids can refer pain into the ear. And so if they have ear pain, it doesn't necessarily mean that they're developing an ear infection or that there is anything going on with the ear itself. It is likely a referred type of pain. For diet, I typically will let kids eat whatever they feel comfortable eating. And so soft and cold tend to be easier to swallow after you've had surgery on your throat. But if they have an appetite for something of more substance, like pizza or a hamburger or whatever, then that's fine. The most important thing is that they are drinking. So lots of water, hydration is key. If they're not wanting to eat a ton, that's okay. I'm not as concerned about the eating, but hydration is really important. And if you're noticing that when they go to the bathroom that their urine or their pee is bright yellow, that is a good sign that they are dehydrated and they need to drink more. And for some kids, dehydration might be a sign that pain is not well controlled. Other things to be on the lookout for: bad breath. Bad breath is extremely common and will get better. It is perfectly fine to brush teeth normally. The area where the tonsils are is further back than where a toothbrush would typically go. So you're not going to hurt or disrupt anything by brushing teeth as you normally would. And then real quickly, talking about kind of complications that we might need to be on the lookout for. I mentioned bleeding earlier. So bleeding, again, for the intracapsular tonsillectomy technique, happens in 0.5% of patients. So very low risk of this happening. When it does happen, if it happens, it might look like some coughing or some spitting up of blood. If that happens, you're going to call your doctor. If you're my patient, you're going to call me, and then we're going to go to the emergency room. For a lot of kids, we can give medications in the emergency room to help stop the bleeding. We might bring you into the hospital and watch you overnight. As long as it has stopped and everything looks fine, go home the next day. For kids who are continuing to have some bleeding from the tonsil, we may need to go back to the operating room, find where that bleeding is coming from, and stop it or cauterize it. And then the patient would go home shortly after that. Because of this risk, I usually recommend that patients are sleeping in the same room as their parents during the recovery period, or at least with a monitor. And the main reason being that is if this were to happen in the middle of the night, the only signs or symptoms that you might notice or hear might be some coughing or choking or gagging. And kids might not be able to, especially if they're if it wakes them from sleeping, or if the lights are out, they may not know what it is. And so out of extreme caution, I recommend sleeping in the same room or having a monitor so that you can hear them and that you can wake up to check on them if you were to hear anything like that. So dehydration can also happen. I alluded to that earlier. Dehydration is going to be more likely to happen if pain is not well controlled. And so let's take, for example, if you were to get into a situation where your child is having so much pain that they are not willing to swallow their pain medication and then are not willing to drink anything. This is more common in the very small kids. Sometimes they end up coming back to the emergency room, getting an IV, getting some IV pain medicine, and then going home after a certain amount of time once they are resuscitated with some fluids and pain medicine. And so I think as long as you stay on top of a pain medication schedule, it is unlikely that you would fall into that category, but it's something to be aware of and does happen sometimes. So that kind of wraps up the high-level overview of tonsillectomy and adenoidectomy in kids. Let me know what questions you have. Drop those comments below, and hopefully you have found this to be helpful. And we will see you on the next episode.